Hello friends, I am Professor Smita Jha from the Department of Humanities and Social Sciences, IIT Roorkee, and I am working on health and disability in humanities. And today's topic is principles of respect for autonomy. Well, this is a course based on medical humanities and disability, which discuss several aspects related to medical science as well as literature. So, in the health humanities, the principle of respect for autonomy emphasizes that individuals have the moral right to make their own choices regarding their health care. This principle requires that we honor a patient's ability to make informed and voluntary decisions about their own body free from any form of coercion. The principle of respect for autonomy is a fundamental moral obligation in bioethics that requires healthcare professionals and researchers to acknowledge a person's right to make their own choices based on their personal values and beliefs. Derived from the Greek words autos, that is self, and nomos, that is rule or law, it translates literally to self governance. Now, let us discuss core pillars of health humanities in relation to autonomy. So, three core pillars of health humanities transform the field of healthcare from a purely mechanistic framework, disease focused model to a holistic, individual centered approach, tailoring medical experiences according to their lived experience, and these are namely relational autonomy. Health humanities scholars argue that individuals are not isolated decision makers, they are deeply connected to their communities, culture, and family networks. Autonomy is viewed as something that is supported or constrained by a patient's social context or relationship. Narrative competence is another point that autonomy is expressed through the stories patients tell about their illness. Health humanities emphasize listening to these narratives to understand what a patient values, fears, and desires, ensuring that treatment aligns with their personal identity and goals. If we come to cultural context, well, it speaks of respecting autonomy means understanding that a patient's values may differ from dominant Western individualistic models of healthcare. It requires navigating how collective or family based decisions play into an individual's choices. For this lecture, we will primarily focus on the pillars of autonomy and how it connects to the principle of respect for autonomy and its related obligations within the field of medical and health humanities. So, the core components and obligations of this particular aspect talks of the principle of respect for autonomy is more than just a respectful attitude. It requires specific actions categorized into two types of obligations. Negative obligation, that is, professionals must not subject an individual's autonomous actions to controlling, constraint, or undue interference. Positive obligation, professionals must actively foster autonomous decision making by disclosing relevant information, ensuring patient understanding, and confirming that choices are made voluntarily. Let us know about the practical applications of the respect for autonomy. The principle provides the ethical foundation for several standard medical practices. So, the informed consent. It is the most direct application where a patient or research participant receives full disclosure of risks and benefits before and alternatives, agreeing to a procedure so that they can make empowered choices. Shared decision making, that is, clinicians act as a partners rather than paternalistic authority figures. They collaborate with patients to build care plans that reflect the patient's personal, spiritual, and philosophical conviction. Dignity and authenticity speaks about respecting autonomy. Providers validate the patient's individual conscience and lived experience, ultimately fostering trust and dignity. Confidentiality and privacy, respecting a patient's right to control their own medical information. Truth telling, the obligation to provide honest and complete information so patient can exercise true self-determination. Coming to the limitation and challenges. Respect for autonomy is a prima facie duty, meaning it must be followed unless a stronger moral obligation overrides it. Harm to other. An individual's autonomy doesn't grant them the right to perform actions that harm others. Competence and capacity. The principles does not apply to individuals who lack the mental capacity to make rational decisions, such as infants, people with severe dementia, or those in a coma. Conflicting principles, it is often balanced against other bioethical pillars such as beneficence, acting in the patient's best interest, and justice fair distribution of resources. In emergencies where a patient is unconscious, the duty of beneficence often takes precedence to save the patient's life. Alternative perspectives. Critics argues that the standard liberal interpretation focuses too heavily on the individual as an isolated actor. Some propose relational autonomy, which acknowledges that people are socially embedded and that their decisions are often influenced by family, culture, and relationship. In many non Western cultures, for example, medical decisions may be made by the family or community rather than the individual alone. So, we'll discuss more about these perspectives later in the lecture. So, coming to the core principles of clinical ethics within principles of respect for autonomy. So, the four core principles of clinical ethics are autonomy, beneficence, non malfeasance, and justice. Now, these principles serve as a practical framework to help healthcare providers navigate complex moral dilemmas in daily patient care. So, as mentioned, the four principles are autonomy, honoring the patient's right to make their own healthcare decisions. Beneficence, acting in the best interest of the patients to promote well being. Non malfeasance, avoiding the infliction of unnecessary harm or pain. Do no harm. Then justice, distributing healthcare resources fairly and treating similar cases equally. So, the interrelations between the principles of autonomy, beneficence, non malfeasance, and justice to cause a bioethical dilemma are given in this chart. That autonomy respecting the values of the patient, beneficence acting to benefit patients by sustaining life and treating illness, non malfeasance refrain from harm, and justice balance between personal needs of the patient and societal resources. So let us now discuss these four principles in greater details. Autonomy. The concept of autonomy as interpreted by philosopher Immanuel Kant and John Stuart Mill is based on the belief that all individuals possess intrinsic and unconditional worth. Consequently, each person should have the ability to make rational decisions and moral choices, exercising their capacity for self determination. This ethical principle was affirmed in a court decision by Justice Cardozo in 1914, who famously stated, "Every human being of adult ears and sound mind has the right to determine what shall be done with his own body." Autonomy, like all four ethical principles, must be weighed against competing moral considerations and may sometimes be overridden. One obvious example of this is when a patient's autonomous action causes harm to others. The principle of autonomy, as mentioned earlier, does not apply to individuals who lack the capacity to act autonomously, such as infants, children, or those who are deemed incompetent due to developmental, mental, or physical disorders. For instance, in the United States, healthcare institutions and state governments have established policies and procedures to assess incompetence. However, the distinction between a clinician's assessment of a patient's inability to make healthcare decisions based on their physical or mental condition and the legal determination of incompetence made by a court is not practically useful. In practice, both assessments have similar implications regarding the patient's decision making capacity. It also then becomes important to understand what the criticisms are of this principle of autonomy. Critics of the principle of autonomy challenge its focus on the individual and suggest the concept of relational autonomy instead. This view emphasizes the influence of social relationships and complex factors such as gender, ethnicity, and culture. Resistance to principle of patient autonomy and its related concepts such as informed consent and truth-telling in non-Western culture is not surprising. In countries with ancient civilization, deeply rooted belief and traditions often lead physicians to practice paternalism, which is driven primarily by the intention to act in the patient's best interest. However, it is important to recognize that culture, a combination of the customary beliefs, social forms, and material traits of a racial, religious, or social group, is not static. Cultures evolve, influenced by changing trends. It is presumptuous to assume that the patterns and roles in physician patient relationship established over the last 50 years still hold today. Therefore, critical examination of paternalistic medical practices is necessary, particularly in light of factors such as technological and economic progress, improved educational and socio-economic conditions for the population globalization, and the societal shift towards recognizing the patients as an individual rather than merely a member of a group. To conduct this examination effectively, research is needed, including well structured surveys that assess demographics, patient preferences regarding informed consent, truth telling, and their decision making roles. In a developed Western country like United States, the culture is diverse and includes various minority populations with respect different from those of the majority white population. For instance, some minority groups may prioritize the need for full discourse and prefer a family-centered approach when making decisions about life support. Furthermore, the principle of respect for autonomy is optimized through informed consent. Providers must explain diagnosis, risk, and benefits clearly so patient can choose voluntarily. While right to refuse, competent patients have the legal and moral right to decline recommended treatments, even life-saving ones. Advanced directives, clinicians honor living wills and durable powers of attorney when patients lose decision-making capacity. So, what is informed consent? The requirement of informed consent for a medical surgical procedure or for research are that the patient or subject must be competent to understand and decide, receives a full disclosure, comprehends the disclosure, acts voluntarily, and consent to the proposed action. The universal applicability of these requirements, which are rooted in and developed from Western culture, has faced some opposition. Some have suggested creating a set of requirements that takes into account the cultural values of other countries. In response and in a strong defense of the 5 requirements for informed consent, as mentioned earlier, Angel stated, there must be a core of human rights that we would wish to see honored universally despite variations in their superficial aspects. The forces of local customs or local laws cannot justify abuses of certain fundamental rights. The right of self-determination, which forms the basis of doctrine of informed consent, is one of these rights. As competence is the first requirement for informed consent, it is essential to know how to identify in competence. Generally accepted standards for determining incompetence include the patient inability to express a preference or choice, difficulty in understanding their situation and its consequences, and incapacity to reason through significant life decision. In cases where a previously autonomous patient is now incompetent, their prior expressed preferences should still be respected. Incompetent patient as well as those who were once competent but are now unable to make decision require a surrogate decision maker. The surrogate can make decision using two standards. First is the substituted judgment standard, which considers what the patient would have wanted in that situation rather than what the surrogate desire. Or second, that is the best interest standard, which evaluates what would yield the greatest overall benefits for the patient by weighing the potential risk and benefits. Snyder and Slumsey offer a practical approach in situations where the surrogate is unsure about the patient's preferences or where the patient's preferences may not align with current scientific developments. They propose that the surrogate should consider substituted interest, which means incorporating the patient's fundamental values and interest into the decision making process. Another aspect, along with competence and incompetence, is truth telling. It is essential aspects of the physician patient relationship. Without honesty, a physician risks losing the trust of the patient. An autonomous patient has the right to be informed about their diagnosis and prognosis, that is disclosure, but they also have the option to decline this information. It is important then for the physician to understand which of these two options the patient prefers. In countries like the United States, full disclosure to patients, regardless of the severity of their illness, has become the norms. This was not always the case. In the past, there was significant resistance to full disclosure among healthcare professionals. For example, in 1961, 88% of physicians surveyed preferred not to disclose a patient's diagnosis. However, by 1979, this attitude has shifted dramatically, with 98% of surveyed physicians favoring full disclosure. This change in perspective is due to several factors, including educational and socio-economic advancements, increased accountability to society, and greater awareness of past ethical lapses in the medical profession. If we look at the surveys conducted in the US, we can find that patients with cancer and other serious illness prefer to be fully informed about their diagnosis and prognosis. It should be the standard practice to provide comprehensive information delivered with tact and sensitivity to those patients who wish to know. Unfortunately, failing to communicate the truth regarding a cancer diagnosis can have significant repercussions. It can prevent patients from completing essential life tasks such as giving advice, saying goodbye to loved one, organizing their financial affairs, including dividing assets, reconciling with estranged family members and friends, and achieving spiritual closure through reflection, prayer, ritual, and religious sacraments. Confidentiality is another important aspect of informed consent within the principle of respect for autonomy. Physicians are required to maintain the confidentiality of information shared by patient and should not disclose this information to others without the patient's consent. An important exception to this rule, which is considered to have implied patient authorization, involves sharing medical information necessary for the patient's care, such as when a primary physician communicates with consultants and other healthcare team. In modern hospitals, where multiple tests and a specialist are involved, along with the use of electronic medical records, the erosion of confidentiality has become a concern. There are some important exceptions to patient confidentiality, which include legally required reporting of gunshot wounds, sexually transmitted diseases, and other exceptional situations that may pose a significant risk to others. This can involve scenarios such as outbreaks of infectious disease, notifying partners in case of HIV, and informing relatives about certain genetic risks. Now, beneficence. The principle of beneficence refers to the obligation of a physician to act in the best interest of the patient. It encompasses several moral guidelines aimed at protecting and defending the rights of others, preventing harm, removing conditions that may cause harm, assisting persons with disabilities, and rescuing individuals in danger. It is important to note that unlike non-malfeasance, which focuses on avoiding harm, beneficence emphasizes positive actions. This principle requires not only the avoidance of harm but also the active promotion of the welfare and well-being of patient. While physicians' commitment to beneficence aligns with moral principles and is fundamentally altruistic, it is also important to recognize that it can sometimes be viewed as a way of repaying a societal debt. This includes the support received from education, often subsidized by governments, as well as the privileges and ranks that come with being a physician, along with a learning and research gained from interactions with patients. Beneficence aimed at maximizing good. Clinicians recommended evidence based therapies, surgeries, or medications that actively heal or alleviate pain and promote holistic care, in which providers align clinical intervention with the patient's specific life goal, values, and definition of well being. Coming to the non malfeasance, it is the obligation of a physician to avoid harming the patient. This essential principle supports several moral rules: do not kill, do not cause pain or suffering, do not incapacitate, do not cause offense, and do not deprive others of the basic goods of life. In practical terms, non malfeasance require the physician to weigh the benefits against the burdens of all interventions and treatments. Physician should avoid those that are unnecessarily burdensome and instead choose the best course of action for the patient. This principle is then particularly important in challenging end of life care decisions such as withholding or withdrawing life sustaining treatments, medically administered nutrition and hydration, and management of pain and other systems. A physician's duty and intention to relieve a patient's suffering, such as severe pain or breathlessness, by using appropriate medications, including opioids, takes precedence over any foreseeable but unintended harmful effect. This is known as doctrine of double effect. You might wonder, then, what is the non malfeasance risk versus benefit? Clinicians must ensure the potential benefits of a painful or risky procedure like chemotherapy outweigh its harms, avoiding futility, withholding or withdrawing painful, aggressive interventions when a condition is terminal prevents unnecessary suffering. Competence, as discussed earlier, healthcare workers must maintain high clinical standards to avoid negligence and accidental harm. Justice, it is generally understood as the fair and equitable treatment of individuals. Among the various categories of justice, distributive justice is particularly relevant to clinical ethics. Distributive justice pertains to the fair, equitable, and appropriate allocation of healthcare resources, guided by justified norms that define the terms of social cooperation. How can this be achieved? There are several valid principles of distributive justice, including distribution of an equal share to each person, distribution according to need, distribution according to effort, distribution according to contribution, distribution according to merit, distribution according to free market exchange. These principles are not mutually exclusive and can often be combined in practice. However, it is important to recognize the challenges in selecting, balancing, and refining these principles to create a coherent and effective approach to distributing medical resources. Within the principles of justice, some other aspects that one needs to remember are fair resource allocation. Triage protocols during emergencies must distribute scarce resources like ICU beds based on medical need, not wealth or status. Non discrimination. Every patient must receive the same standard of evidence based care regardless of race, gender, insurance, or background. Let us now discuss some of the example of distributive justice issues that arise in hospital and office practice. These include the allocation of scarce resources such as equipment, test, medication, and organ transplants, the care of uninsured patient, and the distribution of time for outpatient visit. Should every patient receive equal time, or should it be based on need, complexity, or social economic status? Despite the many challenges, physicians must adhere to the principles of fairness. Now, this principle is crucial, especially when conflicts of interest arise. A clear violation of fairness occurs when a particular treatment option is chosen over others, or when an expensive drug is selected instead of an equal, effective, but less costly one, solely because it benefits the physician financially or in some other way. If we talk of conflicts between principles, each of the four principles of ethics is considered a prima facie obligation that should be fulfilled unless it conflicts with another principle in a specific situation. When faced with such a conflict, the physician must determine the actual obligation to the patient by assessing the relative importance of the competing obligations based on both content and context. For instance, a straightforward conflict may occur when treating a patient in shock who requires urgent fluid resuscitation. The placement of an indwelling intravenous catheter might cause pain and swelling, but in this case, the principle of beneficence, doing good, takes precedence over non-malfeasance, avoiding harm. However, many conflicts physicians encounter are much more complex. For example, consider a competent patient who refuses a potentially life-saving intervention such as mechanical ventilation, or who requests a potentially life-ending action such as withdrawing mechanical ventilation. The clash between the principle of beneficence and autonomy, the right to make one's own choices, is particularly pronounced in these scenarios, making ethical decision making very challenging. So, beneficence has historically played an important role in traditional medical practice. However, prioritizing it over patient autonomy can lead to paternalism, creating a physician patient relationship similar to that of a parent and child. Just as a parent may refuse a child's wishes or influence them through various means, such as non disclosure, manipulation, deception, or coercion, based on their own belief about what is best for the child, physician may also impose their views on patient. Paternalism can be categorized into two types, soft and hard. In soft paternalism, a physician acts based on the principles of beneficence and sometimes non-maleficence when a patient is non-autonomous or significantly non-autonomous. This could be due to conditions like cognitive impairment from severe illness, depression, or drug addiction. Soft paternalism can be complex, as it can be challenging to determine whether the patient was non-autonomous during the decision-making process. However, it is considered ethically justifiable as long as the physician's actions align with what they believe to be the patient's values. On the other hand, hard paternalism involves a physician taking action intended to benefit a patient, but these actions go against the voluntary decision of a fully informed and competent autonomous patient. Hard paternalism is considered ethically indefensible. At the opposite end of the spectrum from hard paternalism is consumerism, which represents a rare and extreme form of patient autonomy. This viewpoint asserts that the physician's role is limited to providing all relevant medical information and the available options for interventions and treatments, while the fully informed patient make the final choice. In this model, the physician's abilities and knowledge are not fully utilized to benefit the patient, leading to a situation that can be seen as patient abandonment, rendering it ethically indefensible. In light of the contrasting paradigms of beneficence and respect for autonomy, it is essential to reconcile these concepts to find common ground. Furthermore, Pellegrino and Tomasama argue that beneficence can encompass patient autonomy, suggesting that the best interests of the patients are intimately linked with their preferences, which informs our primary duties to them. One common reason for disagreement between physicians and patients regarding treatment is their differing views on treatment goal. As a disease progresses, such as when a chronic neurological condition worsens to the point where ventilator support is needed, or when cancer becomes resistant or treatment, the physician must clearly communicate with the patient. This communication should be straightforward and free of medical jargon, clearly defining the new goals of treatment based on the changed circumstances. Additionally, the physician should be aware of patient factors that may affect their ability to make decisions. These factors can include anxiety, fear, pain, lack of trust, and differing beliefs and values, all of which can impair effective communication. If we talk of resolving conflicts between principles in real world practice, these principles frequently clash. For example, if a competent patient refuses a life saving blood transfusion due to religious beliefs, autonomy directly conflicts with beneficence. To resolve these dilemmas, clinical teams use a structured ethical framework. The four boxes approach, analyzing medical indication, beneficence, non-malfeasance, patient preference, autonomy, quality of life, beneficence, non-malfeasance, and contextual features, that is justice. Now, ethics consultations, that is convening multidisciplinary committees to review the case, mediate discussions and guide the care team toward a balanced decision. If one wants to explore how these apply to a specific scenario, the questions that can be asked are: what is the medical condition or scenario? Which principles seem to conflict in your case? Is there a specific legal or cultural factor involved? So, role of ethics in the principle of respect for autonomy is a comprehensive field that examines morality and the specific moral choices individuals encounter. Normative ethics aims to address the question which general moral norms should be accepted to guide and evaluate our action and why. So there are further different types of moralities within these principles, namely common morality, certain moral norms such as prohibitions against killing, harming others, or causing suffering, are widely recognized across different cultures, regions, religions, and group identities. These norms collectively compose what is referred to as common morality. Particular morality, in contrast, particular morality pertains to norms that are specific to certain groups based on their cultural, religious, and professional context. An example of particular morality is the expectation for physicians to deliver competent and trustworthy care to their patient. Various physicians organizations at local, state, and national levels have established formal standards to define this role. However, it is acknowledged that adherence to these standards may not always be in alignment with broader moral norms, as these codes can occasionally prioritize the interest of the profession or overlook significant issues affecting patients and society. Furthermore, several severe abuses of human subjects in research, such as medical intervention conducted without informed consent and experimentation in concentration camps during World War II, have highlighted the need for ethical standards. At the same time, significant advancements in medicine and technology, alongside changes in society, have contributed to the rapid evolution of bioethics. This field has expanded from a focus on professional conduct and codes to encompass a broad range of areas, including research ethics, public health ethics, organizational ethics, and clinical ethics. With this, I wrap up the discussion. Let us discuss some other important related issues to health humanities. Till then, thank you.